Welcome back, future nurses and NCLEX champions. As part of our ongoing daily high-yield NCLEX series, where we simplify complex topics into clear, exam-ready concepts, today we are diving into one of the most important and frequently tested endocrine disorders, diabetes mellitus. In this session, we will break down the complete picture of diabetes mellitus, including the pathophysiology of type 1 and type 2 diabetes, insulin resistance, beta cell dysfunction, and the role of glucose metabolism in the body. We will clearly differentiate between hyperglycemia and hypoglycemia, understand acute complications such as diabetic ketoacidosis and hyperosmolar hyperglycemic state, and review long-term microvascular and macrovascular complications affecting the kidneys, eyes, nerves, and cardiovascular system. At the end of the topic, we will also discuss some questions. Hold on, don't skip this, because what I'm about to share could be the difference between passing and retaking your NCLEX. The ultimate NCLEX crash course, trusted by over 100,000 nursing students, gives you a fast track to success. Imagine having everything, live and recorded lectures, 5,000 exam questions, 30 practice tests, ebooks, PDFs, planners, and NGN deep dives, all in one place. This is your shortcut to confidence and clarity. Scan the QR code right now or click the link to enroll and unlock free notes, quizzes, and exclusive NCLEX test sets. You'll also get instant access to our Telegram and WhatsApp learning groups filled with daily tips and free resources. Now let us begin with one of the most tested and clinically significant endocrine disorders you will ever encounter in advanced practice and on the NCLEX examination, and that is diabetes mellitus. As we move step by step through this topic, I want you to think beyond memorization and start understanding the pathophysiology, because once you understand the mechanism, answering complex questions becomes effortless. Diabetes mellitus is a chronic metabolic disorder characterized by persistent hyperglycemia resulting from defects in insulin secretion, insulin action, or sometimes both. In simple terms, glucose is present in the bloodstream, but it is not effectively entering the cells where it is needed for energy. Consequently, despite high blood sugar levels, the cells are essentially starving. Before we go deeper, let us briefly recall normal values, because NCLEX questions often begin there. A normal fasting blood glucose level ranges from 70 to 99 milligrams per deciliter. Diabetes is diagnosed when the fasting blood glucose is greater than or equal to 126 milligrams per deciliter. A random blood glucose is greater than or equal to 200 milligrams per deciliter with symptoms, or when the hemoglobin A1C is 6.5% or higher. Therefore, whenever you see those numbers in a question stem, your clinical reasoning should immediately activate. Now that the foundation is clear, let us transition into the types of diabetes mellitus, because differentiating them is extremely important for MSN-level understanding. First, we have type 1 diabetes mellitus, which is an autoimmune disorder characterized by destruction of the pancreatic beta cells located in the islets of Langerhans. As a result of this autoimmune destruction, the body produces little to no insulin, leading to absolute insulin deficiency. These patients are often diagnosed in childhood or adolescence, although it can occur at any age. Because insulin is completely absent, lifelong insulin therapy is mandatory for survival. Most importantly, these patients are highly prone to developing diabetic ketoacidosis, which is a life-threatening emergency that we will discuss shortly. Moving forward, let us now shift our focus to type 2 diabetes mellitus, which is far more common in clinical practice. Unlike type 1, type 2 diabetes mellitus is primarily characterized by insulin resistance combined with a relative insulin deficiency. This means insulin is present, but the cells do not respond to it effectively. Over time, the pancreas becomes exhausted and insulin production decreases further. This condition is strongly associated with obesity, sedentary lifestyle, genetics, and metabolic syndrome. Instead of diabetic ketoacidosis, these patients are more likely to develop hyperosmolar hyperglycemic state, which is marked by extremely high blood glucose levels without significant ketosis. Next, let us briefly address gestational diabetes, which occurs during pregnancy due to placental hormone-induced insulin resistance. Although it typically resolves after delivery, it significantly increases the mother's risk of developing type 2 diabetes later in life. Additionally, it increases the risk of having a large for gestational age infant and neonatal hypoglycemia. Therefore, screening and early management are critical. Having discussed the types, let us now dive deeper into the pathophysiology, because this is where MSN-level critical thinking becomes essential. When insulin is absent or ineffective, glucose cannot enter the cells. Consequently, blood glucose rises. Simultaneously, the liver increases gluconeogenesis and glycogenolysis, further worsening hyperglycemia. As blood glucose exceeds the renal threshold, glucose spills into the urine, pulling water with it. This osmotic diuresis leads to polyuria. Because of excessive urination, dehydration develops, which triggers polydipsia. Meanwhile, since cells are unable to utilize glucose effectively, the body signals hunger, leading to polyphagia. Therefore, the classic triad you must remember is polyuria, polydipsia, and polyphagia. Now let us transition into acute complications, which are frequently tested on the NCLEX and are clinically life-threatening. First, consider diabetic ketoacidosis, commonly seen in type 1. In this condition, due to the absence of insulin, the body begins breaking down fat for energy. Fat metabolism produces ketones, which are acid. As ketones accumulate, metabolic acidosis develops. Blood glucose levels are usually above 250 milligrams per deciliter. Patients may present with Kussmaul respirations, which are deep and rapid breathing patterns, as the body attempts to compensate for acidosis. Fruity breath odor may also be present due to acetone. Management begins with aggressive intravenous fluid resuscitation, followed by intravenous insulin therapy and careful potassium monitoring. Remember this NCLEX priority. Fluids are administered before insulin if severe dehydration is present. In contrast, hyperosmolar hyperglycemic state occurs primarily in type 2. Here, blood glucose levels may exceed 600 milligrams per deciliter. However, because some insulin is still present, ketosis is minimal or absent. Instead, profound dehydration and neurological changes dominate the clinical picture. Treatment again centers on aggressive intravenous fluids, insulin infusion, and electrolyte correction. As we move from acute to long-term consequences, it is crucial to understand chronic complications. These are divided into microvascular and macrovascular complications. Microvascular complications include diabetic retinopathy, nephropathy, and neuropathy, which result from prolonged capillary damage due to chronic hyperglycemia. Macrovascular complications include coronary artery disease, stroke, and peripheral arterial disease. Therefore, strict glycemic control is not only about preventing symptoms today, but also about preventing blindness, kidney failure, and cardiovascular events. Next, let us briefly review medications. Insulin therapy remains the cornerstone of treatment in type 1 and advanced type 2. Insulin is categorized as rapid-acting, short-acting, intermediate-acting, and long-acting. Only short-acting insulin is administered intravenously, particularly in emergency situations like diabetic ketoacidosis. Injection sites should be rotated to prevent lipodystrophy. Among oral antidiabetic agents, metformin is commonly prescribed. It works by decreasing hepatic glucose production and improving insulin sensitivity. However, it must be temporarily withheld before contrast studies for the risk of lactic acidosis, especially in patients with renal impairment. Now, let us shift towards nursing management, because this is where your MSN role becomes highly impactful. Nursing care includes regular blood glucose monitoring, nutritional counseling with carbohydrate control, individualized exercise planning, medication adherence education, and comprehensive foot care. Patients should inspect their feet daily, avoid walking barefoot, trim nails straight across, and report non-healing wounds immediately. Early detection prevents amputation. Finally, let us discuss hypoglycemia, which is equally important and often tested. Symptoms include sweating, tremors, confusion, and tachycardia. If the patient is conscious, administer 15 grams of a fast-acting carbohydrate and recheck blood glucose in 15 minutes. If the patient is unconscious, administer intravenous dextrose or intramuscular glucagon. Always treat hypoglycemia first because it can rapidly lead to brain injury. As we conclude this session, remember that diabetes mellitus is not merely a disorder of elevated blood glucose. Rather, it's a complex endocrine condition affecting every organ system. Mastering the differences between type 1 and type 2 diabetes, recognizing diabetic ketoacidosis versus hyperosmolar hyperglycemic state, understanding medication mechanisms, and prioritizing nursing interventions will significantly improve both your clinical competence and your NCLEX performance. Now, let us see some important scenarios. Hold on, don't skip this, because what I'm about to share could be the difference between passing and retaking your NCLEX. The ultimate NCLEX crash course, trusted by over 100,000 nursing students, gives you a fast track to success. Imagine having everything: live and recorded lectures, 5,000 exam questions, 30 practice tests, ebooks, PDFs, planners, and NGN deep dives, all in one place. This is your shortcut to confidence and clarity. Scan the QR code right now or click the link to enroll and unlock free notes, quizzes, and exclusive NCLEX test sets. You'll also get instant access to our Telegram and WhatsApp learning groups filled with daily tips and free resources. Let us begin with question 1. The question asks, diabetes mellitus is primarily characterized by which underlying problem? The options include increased glucose uptake into cells, chronic hypoglycemia, hyperglycemia due to defects in insulin secretion or action, and excess insulin production. Now, think carefully. The correct answer is hyperglycemia due to defects in insulin secretion or action, and here is why. Diabetes occurs because insulin is either insufficient or ineffective, leading to persistent elevation of blood glucose levels. It is not increased glucose uptake, and it's certainly not chronic hypoglycemia. Moving forward to question 2, which focuses on diagnosis. Which fasting blood glucose value confirms diabetes mellitus? The options include 90 milligrams per deciliter, 110 milligrams per deciliter, 126 milligrams per deciliter, and 99 milligrams per deciliter. The correct answer is 126 milligrams per deciliter. Remember this clearly for the NCLEX. A fasting blood glucose of 126 milligrams per deciliter or higher confirms diabetes. Values such as 99 or 90 are still within normal limits. Next, let us shift our attention to the mechanism of type 1 diabetes in question 3. The question asks, type 1 diabetes mellitus results from which mechanism? The options include insulin resistance, autoimmune destruction of pancreatic beta cells, excess glucagon secretion, and obesity-related insulin overproduction. The correct answer is autoimmune destruction of pancreatic beta cells. This destruction leads to absolute insulin deficiency, which is why lifelong insulin therapy is required. Now, building on that concept, question 4 asks which acute complication is most commonly associated with type 1 diabetes. The options include hyperosmolar hyperglycemic state, hypoglycemia unawareness, diabetic ketoacidosis, and peripheral arterial disease. The correct answer is diabetic ketoacidosis. Because there is absolute insulin deficiency, the body begins breaking down fat, producing ketones, and leading to metabolic acidosis. Let us now compare that with type 2 diabetes in question 5. The question asks, which finding is expected in hyperosmolar hyperglycemic state? The options include blood glucose above 600 milligrams per deciliter, significant ketone production, metabolic acidosis, and fruity breath. The correct answer is blood glucose above 600 milligrams per deciliter. Unlike diabetic ketoacidosis, hyperosmolar hyperglycemic state typically does not involve significant ketosis or acidosis, but it does involve profound hyperglycemia and dehydration. As we continue, question 6 brings us back to classic symptom recognition. Which symptom triad is commonly seen in uncontrolled diabetes mellitus? The options include polyuria, polydipsia, and polyphagia, bradycardia, hypotension and hypothermia, jaundice, ascites and edema, hematuria, dysuria, and urgency. The correct answer is polyuria, polydipsia, and polyphagia. These symptoms occur because excess glucose in the blood causes osmotic diuresis, dehydration, and cellular starvation. Now let's transition into management priorities in question 7. The question asks, which intervention has priority in managing diabetic ketoacidosis? The options include administering insulin immediately, providing aggressive IV fluids, restricting oral intake, and administering oral hypoglycemic agents. The correct answer is providing aggressive IV fluids. On the NCLEX and in real life, fluids come before insulin when the patient is severely dehydrated. Next, question 8 shifts our focus to chronic complications. Which condition is considered a microvascular complication of diabetes? The options include stroke, coronary artery disease, retinopathy, and peripheral arterial disease. The correct answer is retinopathy. Retinopathy results from chronic damage to small blood vessels, whereas stroke and coronary artery disease are macrovascular complications. Continuing further, question 9 addresses insulin therapy. Which insulin type can be administered intravenously? The options include long-acting insulin, intermediate-acting insulin, rapid-acting insulin, and short-acting insulin. The correct answer is short-acting insulin. Only short-acting insulin is approved for intravenous administration, particularly in emergency situations such as diabetic ketoacidosis. Finally, let us conclude with question 10, which tests your ability to recognize and treat hypoglycemia. A conscious patient with hypoglycemia should receive which initial treatment? The options include intravenous insulin, 15 grams of fast-acting carbohydrate, long-acting insulin, and potassium infusion. The correct answer is 15 grams of fast-acting carbohydrate. This follows the 15-gram rule. Give 15 grams, recheck in 15 minutes, and repeat if necessary. Thanks for watching. We will see you in next video.